disclaimer, I am not athletic nor am I coordinated, so thank you. Hello everybody, my name is Elizabeth, also known as NURSEZABE here on YouTube and Instagram, and I am so happy to be here with Dr. Michelle Little, who has her own Instagram. She is a pelvic floor physical therapist, and I'm going to let her introduce herself a little bit more and kind of give a plug to all of the wonderful, amazing classes that she has going on right now.
Thank you, Elizabeth. My name is Michelle Little. I am a physical therapist here in Charlottesville, Virginia. I have postdoctorate specialties in obstetrics and pelvic health, and I'm also board certified as an orthopedic clinical specialist. So our specialties here at Women in Motion is orthopedics, obstetrics, and pelvic health. So we see a lot of prenatal, postpartum, but also kind of put the whole picture for women. So whether you're a runner, lifter, or just like to exercise and are having aches and pains, and you're either prenatal, postpartum, or menopause, that is essentially who we see.
Awesome. And you do have a couple of classes that I wanted to highlight because not all of you are going to live next to a pelvic floor physical therapist. She has a prenatal and a new postpartum class. Can you tell us a little bit about those?
Yeah, so I have our pregnancy prep class, which is designed intentionally from a pelvic PT's perspective. And so it goes through different exercises that you need. We have prenatal yoga. It has a pelvic floor screen and a diastasis recti screen. But then it also has a labor and delivery portion to help prepare your birth partner, support you in the labor and delivery room. And then we have a postpartum class, which is a 12-week class, and it's designed to take you from wherever you are in your postpartum journey back to exercise. And we have modifications on there for incontinence, pelvic organ prolapse, and diastasis recti.
Perfect. So I saw Dr. Little at the beginning of my pregnancy. With my previous two pregnancies, I had issues with symphysis pubic pain. And so we did some exercises and some modifications to kind of help strengthen everything for the rest of my pregnancy. And now I'm seeing her postpartum at like 9 months postpartum, where ideally it would have been closer to that 6-month mark, but you know, life happens. And I am still having a little bit of that pubic symphysis discomfort pain and a lot of hip pain with exercise. And when I say exercise, I mean walking, like going on walks, which is exercise, but not like super strenuous. So I want to kind of deal with that. And also I did have some diastasis recti during my pregnancy that I know is still there as well, just based on how my abdomen is looking. So I would love some exercises to help with that. And then during, or I guess postpartum, with Rosie, for about the first 3 weeks, I was having a lot of like heaviness, feeling like I needed to stool, but like wasn't able to go, always having that urgency feeling there. And that has resolved, but I just kind of want to get everything checked out there with any sort of prolapse. So I thought it would be fun to bring you guys along so you could see what a pelvic floor assessment looks like. We're obviously gonna kind of cut some things together. You're not gonna see all the fun things, but this way, if you go in for a pelvic floor appointment, you kind of know, okay, this is what to expect, this is what things will look like. And one pro tip that I learned from last time is you should actually come in like exercise attire, because I didn't realize that, and then I was wearing like Uggs and no socks, and it was just like a whole mess. So that's my pro tip for you before we get started. Any other reasons why someone might see a pelvic floor PT that you might want to like highlight on, and then of course we can throw up any other additional ones on the screen.
So just in general, I think it's important to understand that pelvic PTs serve all genders, all phases of life. There's a pediatric specialty, both male and female care, and then prenatal, postpartum, and menopause. And I think that's important because when you're looking for a pelvic health therapist in your area, you want to find out, like, do they serve the prenatal and postpartum population, since that's kind of like the focus that we're gonna do today, because maybe they just treat geriatrics or pediatrics, or maybe they just do incontinence but don't see prolapse. And so those are questions that you want to ask, and we'll just put up a slide with some other reasons why you might see a pelvic PT, but essentially it's bowel, bladder, sexual dysfunction.
So I guess what we can go ahead and do, we've already done a little bit of a health history together, but that's something that you would do immediately when you see a physical therapist. They're going to kind of go over, okay, what are your complaints? Let's talk about, are you having any issues with sexual discomfort, with orgasm, bowel or bladder incontinence, anything like that. And then I think what we can do now is do a little bit of like what the physical assessment would look like. So look at my stomach for that separation of my ab muscles, and then show you what the setup will look like for an actual pelvic exam.
So for the diastasis recti exam, I want to look at your abdominal muscles when you are relaxed and when you are engaged, and then we will do trunk up and then we'll do feet up just to see, different types of exercises that you might be doing, how your body is responding, okay?
Okay.
So first what I'm going to have you do is don't worry about engaging anything. I just want you to curl up. You're going to lift your head and shoulders off the table for me. So, okay, right here, I can put my fingers, I have 2 fingers between the 2 rectus abdominis muscles. Okay. And so I'm feeling how deep can I sink? And then can I separate it any further? So right there, if you put your fingers in there, you can probably separate to about 3 finger width at the top. Curl up one more time for me. And then, let's see, below the belly button, there's nothing. So
way to go.
Only up above. Just curious, was she a little higher up, or?
Yeah, she didn't drop until labor, so that might be why.
Yeah, I tend to see with moms that carry a little heavier, sometimes they'll have separation higher up versus if baby's really low, sometimes it's more at the belly button and below. So everyone's a little different.
Okay.
And then let's see if we can engage your core and pelvic floor muscles, and if we can make that separation a little bit smaller by engaging your transverse abdominis. So I'm going to have you inhale for me. And then exhale, think about drawing belly button to spine. And then think about squeezing your anus as if you're trying to not pass gas. Okay. So that will get the highest EMG activity of the pelvic floor. And then now let's just take another deep breath. So you're going to inhale, exhale, belly button to spine, engage pelvic floor, hold that. And then go ahead and lift up for me again. Good. And so that's amazing. There is actually endurance is an issue. But when you came up, there was no separation there. So that's fantastic. So I want you to do this so that your followers can see that they can kind of self-screen for this themselves. Yeah. So don't engage, and I'm going to have you just curl up for me. And so I want you to put fingers right here. So do you feel how you can feel rectus abdominis, and then as you hold it more, and endurance kind of takes hold, it starts to gap a little bit more. Yeah. And then now come down, and then we're going to engage so you can feel the difference. So inhale, exhale, squeeze your anus, curl up, and then do you feel how?
I don't feel it at all.
Yeah, exactly. So that is a functional diastasis. So that means if you're engaging your core and pelvic floor muscles in any supine exercises, that you can do those safely. We'll have to figure out endurance-wise where you are. But that's the number one question people have is what exercises can I do? And this is why doing at least a basic screen is so important to help us decide that.
A few things off camera, and Michelle's going to explain what she was looking for and kind of the findings that she had. We were kind of looking at my SPD and hip pain and everything.
This is something that you may or may not have as part of your evaluation, because I am also board certified as an orthopedic clinical specialist. All of our patients also get an orthopedic exam. So with Elizabeth, we looked at her general posture. She's also having some low back pain with a lot of carrying baby. And so we looked at her low back, her SI, her pubic symphysis. And then I also assessed strength. So I looked at her glute strength, her overall stability, and then we did the diastasis. And then we did the diastasis recti exam, which will be included in this for you guys to see. I think that's really important because the pelvic floor muscles don't work in isolation, but whether you are seeing a pelvic PT that has a strong orthopedic background may depend on whether that is part of your evaluation, or your pelvic PT might have an orthopedic therapist that she co-treats with.
Okay.
So.
Cool.
And what we wanted to do now is go over generally what a pelvic exam would look like, and then different options for that and where you would get consent. So with pelvic floor, I like to look at the external pelvic floor muscles and the internal pelvic floor muscles. The external pelvic floor muscles are these guys. This is what you can kind of palpate if you were just to kind of touch around the vulva. Here, these muscles play a major role in sphincter control. So especially if we're looking at that bulbocavernosus that it wraps around the vulva and helps form part of that perineum. These muscles literally wrap around the urethra, the vagina, and the rectum, and so their job is to help keep things in when we want them to stay in, and then they also lengthen and relax so that we can pee, poop, and have sex.
And have babies.
And have babies. For postpartum moms specifically, a couple things that I'm looking at is first doing a neural screen. So when we have babies, our body is so amazing and can lengthen to allow baby to come out, but sometimes that can result in different kinds of nerve traction injuries. So I will use a Q-tip and I'm going to check 4 different areas and I'm going to look at sensation. I'll show you on the inside of your leg so that you know what to expect, and I'll show you what soft feels like and what scratchy feels like, and then you'll tell me, do you feel it on the right side or the left side, and what you're feeling.
Okay.
Then I'm going to inspect the area where there was some perineal tearing.
I had a 2nd-degree tear, which means that it tore through the skin and through the muscle of the perineum, which is between the base of the vagina and the anus.
And so I always like to see if there's any scar tissue there, if there's any sensitivity. So for many women, that can result in pain with penetration, pain with orgasms, because as you have scar tissue here, it's hard for the clitoris to move during an orgasm, resulting in pain. It can also affect sphincter control, so that can lead to a little bit of bowel leakage or urine leakage. And so I'll look at that with the Q-tip. I'll kind of palpate right where that scar is and if there's any pain there. I'll then move the labia out of the way so that we can really get a good look at the vulva, the urethra, the vaginal opening. And then what I'm looking at there is, are there any bulges, any signs of prolapse? Is of skin integrity, so does it look like there's been good healing, which at this point we expect, but also with breastfeeding or lactating moms, sometimes we can see some signs of estrogen deficiency where that vaginal wall is a little thinner, and that can actually result in pain with penetration, because if that wall's thinner, if a penis or a toy going in, you get that friction pain, and that can be some of that burning pain that you sometimes feel when you void or pee after intercourse. I'll have you do a pelvic floor contraction, and so what I'm looking at are, do these external muscles contract? Do we see that that anus is also able to contract?
And that's a Kegel, right? A pelvic floor contraction is a Kegel? Or?
Yes,
Okay.
essentially. I'll have you cough. There'll be a chest pad on the table, and so that's just a stress test to see if there's any leakage when she coughs. Also, if you do see any bulges like prolapse when she coughs, do we see any movement there?
Okay.
Then with the internal exam, we are looking at the deeper layer of the pelvic floor muscles that play a major role in stability, especially like stabilizing the pelvis for running or any kind of single leg exercises. Levator ani to the right and the left, those muscles help play a major role in supporting our pelvic organs, so the bladder, uterus, and rectum. And so digitally here, what I'll be doing is 1, feeling the muscles and seeing if there's any kind of increased tone. If there is tone, is that painful to her or a similar pain that you might feel with intercourse? And we're going to look at your ability to contract those muscles, hold them for 10 seconds, so checking your endurance, and then being able to relax.
Okay.
This is important because with endurance, sometimes we have patients that will say things like when they go running, they'll leak after mile 5. Or if they're doing double unders or a workout, maybe they leak halfway through it. And so seeing the endurance component of your pelvic floor is really important. And then seeing that you can fully relax is important because we need that to pee, poop, have sex, and have babies. For today, that's kind of what we're going to focus on. Based on your symptoms and what you have, I would say this is pretty standard, but then we can go into a lot more depth and further testing more specific to if you are a runner or if you're having more bladder, bowel dysfunction.
Okay.
So I set up the table, and so there's a chest pad on the table just so that patients always feel really comfortable with any kind of stress test. Sometimes things come out, and that's okay. Then we'll go on the chest pad, and then you'll cover up with this top sheet. I'm going to step out, let you get changed. You can keep your shirt on. We just undress waist down. I'll give you a couple minutes. I'll knock and let me know when you're ready.
Okay, perfect. Thank you. So Michelle just went ahead and did my internal exam, and we had some findings. I'm going to share in layman's terms what I heard, and then she's going to kind of explain what that means. So basically, with my exam, what we noticed is that I have a propensity for like bearing down instead of like contracting everything, which makes sense because I have struggled in the past with hemorrhoids, and I also have a pretty slight prolapse of my bladder and a slight prolapse of my rectum. obviously, even if you have this exact same diagnosis, the treatments, everything's going to look different because it's all very individualized on what is your pelvic floor doing and why is this occurring. Dr. Little's just going to talk a little bit about what she found and what that might look like and how you can kind of, yes, look and see if you have this at home, but then if you see anything, you obviously want to go see a provider because you don't know exactly what you're seeing.
So with the exam, a couple of things that we're looking at is when I do the external assessment with Elizabeth, we saw a little bit of an anterior bulge, and so that tells me that her anterior vaginal wall is coming down a little bit, and then I had her cough and bear down, and we saw how much movement there was there. At rest, we could also see a little bit of the posterior vaginal wall coming up. So if you think of the way we tested, she was on her back on the table, the shape of the rectum, for us to be able to see it, it was pretty far forward. And then we saw that with both coughing and bearing down, it kind of moved a little bit closer down to the introitus. With Elizabeth, it's not symptomatic, so she doesn't have any heaviness or pressure, and she's not having any leakage. And so I think that's important to note because prolapse can be symptomatic or asymptomatic. Symptomatic, most common, heaviness, pressure, feeling like something's falling out, and then organ specific. So with a cystocele or a bladder prolapse, you might have more leakage, and that could be coughing, sneezing, but also with movements. If you have a rectocele, that could be like having to splint to have a bowel movement or having to rock back and forth to fully empty. And again, kind of like overall, like with increased exercises, that heaviness and pressure feeling. If you were to look with a mirror, typically you'll see some form of bulge in the area, but like Elizabeth said, always recommend that you see a medical provider to make sure that it is prolapse and not something else, and then seeing a pelvic PT for a specific program for you, because figuring out the why is really important to be successful with treatment. And then I guess some other things just to note is like you guys are seeing that the picture right now of the vulva. We also, there are urethral prolapses. We can look at the vaginal wall and see if there's any kind of estrogen deficiency or atrophy. And that can play a major role if you're having any pain with intercourse, which we've done the pain with sex video before.
Yeah, I'll link that. You guys can go watch that if you want to see more of Dr. Little.
But that's important to know too, because if you're having any bleeding with intercourse or penetration, or pain with penetration, figuring out if that's the muscles that are causing kind of more tightness around the opening and pain, or scar tissue from tearing, or if it's the friction from the atrophy of the vaginal wall, is really important to be successful with treatment. And this is why we always love collaborating with our medical providers so we can make sure we can best serve these patients.
But I guess next step for us is we are going to work together on doing some exercises, on figuring out how to strengthen everything so that I'm in tip-top shape for you guys. Okay,
Thank you.
Cool. Let's go do some exercising.
Perfect.
So, obviously different day, different clothes, but that's because we talk too much. So we're going to go over a little bit of what my treatment plan is going to look like, including some exercises. We're going to talk really briefly on Kegel weights because that's something that Dr. Little thought would be really beneficial to kind of help strengthen my pelvic floor and help with my symptoms of prolapse and also help with my SPD pains.
One of the things that's really important to understand is when women have pubic symphysis pain, kind of traditional orthopedic therapists tend to work on core strengthening and glute strengthening, but what we forget is that the pelvic floor muscles are really the only muscles that attach front to back, so they are the primary stabilizers for that pubic symphysis. And so with Elizabeth, what we're going to be working on is improving hypertrophy, so thickness of those muscles, and the best way to do that is with Kegel weights, right? So if you think about going to the gym, trying to strengthen your biceps so that you have a little bit more muscle tone, we would do that with weights, not just squeezing your bicep muscle. And so when you just squeeze your bicep muscle, that is an isometric contraction. That is the equivalent to a Kegel or a Kegel, where you just maximally squeeze and then release. So very similar to what the LV does. So those are great to get the muscle activated, but it's not functional. So with Elizabeth, we were digging a little bit more that her SPD flares up when she walks uphill, pushes the stroller, right? So more functional movements. So we're going to be using the Kegel weights to help build up tone in her pelvic floor, and that will also help to support her pelvic organs a little bit better. With Elizabeth, we're going to go over 3 exercises that are going to be part of her home program. Very important to know that if any of you guys have pubic symphysis pain, These may not be appropriate for you. Elizabeth doesn't have any pain with single leg jabs or single leg stance. The more acute stages or higher severity of pubic symphysis pain, those would be moves that would really trigger the pain. So we are doing higher level exercises with her. So again, just a disclaimer, if you have pubic symphysis pain, this may not be appropriate, and so we would recommend working with a pelvic PT to get a program specific for you.
Also, another disclaimer, I am not athletic nor am I coordinated, so thank you.
Okay, so first exercise we're going to do here is we're going to work on some single leg squats. The goal here for Elizabeth is she wants to, we live in a very hilly neighborhood, and so she wants to be able to push her stroller up and down hills and not have the pubic symphysis pain. So we're going to work on glute strengthening, quad strengthening, and adding in a core and pelvic floor component here. We're going to do single leg because asymmetrical movements tend to flare up the pubic symphysis joint, but because she's not symptomatic with those movements, it's a great place to strengthen her. So here, you are going to inhale for me, then we're going to exhale, engage the core, engage the pelvic floor, and you are going to squat back. So, yep, and then you're going to come up. Good, and then you're going to reset, inhale, relax, exhale, engage, and then you're going to sit back. So goals here is we want to make sure, good, you come up, we want to make sure that knee isn't going in too far. That puts more stress on the ACL. It's not going too far over, and she can use the pole or a doorway or TRX to decrease how much weight and pressure she's putting on her body. So try like 3 more of those for me. So engage before you go down. Good. And then squat down and then up. Beautiful. Inhale. Exhale, engage. Squat down. Good. And then come up. Good. One more. Inhale down. And then exhale, engage. Good. And then come up. Perfect. And so over the next 2 weeks, she'll work on this, get a little deeper into her squat, and as her quads and glutes get stronger, we won't see as much of that valgus movement. More importantly here, we're also working on coordination of her core and pelvic floor. So second exercise, we're going to work on lunges, great transitional movement, same patterns as walking. So here, I'm going to have you, we're going to lunge down, so you're inhaling, lunge down.
Okay.
Good. And then at the bottom of the lunge, you're going to exhale, engage core, pelvic floor, and we're going to drive up. Beautiful. Inhale down. Great form. And then exhale, come up. Good. And so the goal here is at the bottom of the lunge, right before you come up, that she's able to engage her core, pelvic floor, giving her pelvis support before she starts that asymmetrical movement to reduce any kind of strain in the pubic symphysis joint.
Perfect.
This is going to be the final exercise that I'm going to give her for her home program. Here we're going to work on double leg to single leg bridge. And so you're going to inhale, relax the belly, exhale, belly bend the spine, draw up your anus, engage that pelvic floor, hold it, lift up into a bridge. Good. And then see if you can straighten out one leg for me. Good. And we're looking at pelvis should stay neutral. She's still holding core and pelvic floor. Bend the knee. And then we're going to come out of it. Now here, you're going to inhale. Good. Exhale, engage core, engage pelvic floor, bridge up. And then lift one leg out. 1, 2, 3, 4. Bend the knee. And then come out of it. Perfect. So we're just, again, working on engaging core and pelvic floor to provide stability before she creates these asymmetrical movements.
Anything else that you'd like to add about seeing a pelvic floor PT postpartum? Or you do have a postpartum class, and there's a discount code. Do you want to talk a little bit about that? Because for those who maybe don't have the money right now to see a pelvic floor PT or don't have one in their area, this can kind of be a bridge until you're able to do so.
Our postpartum class is a 12-week program. It was intentionally designed the same way that we would treat our patients. So there's a strength component, a mobility component, and an education component. So there are education modules on common women's health conditions like prolapse, incontinence, treatments, pain with sex, C-section scar recovery, and then there is a self-screen so that you can better understand your anatomy, what you're looking at, and it's really just designed to help you advocate when you see your primary care physician or your gynecologist or midwife on some of your concerns and changes. And then the 12-week program starts very basic, and then we build up to high-level plyometric strength exercises. And throughout the whole course, we have tons of modifications, and we also have Q&A live check-ins. So every quarter we run challenges where myself and some of my pelvic PTs hop on, and we get on to answer questions and provide you with other resources. And I'll give you guys a discount code so that you can check it out.
Awesome, and that'll be linked in the description.